Given the marked variability in the anatomy and morphology of the left atrium and the left-fated appendage, we need increase our knowledge when we are planning our procedure for left-atrial appendage occlusions. We need to identify the epicardial and endocardial gross morphological features of the left atrium and the left-fated appendage, and even to know the more important landmarks when we are approaching the left atrial appendage. We can distinguish within the left atrium 4 components: the septum, the venous component, the appendage, and the vestibule. These 4 components are the same for the right and the left atrium. And we have the same component, the interatrial septum, for both left and right atrium. And here you can see, on the right, you can see the mitral valve, the vestibule of entrance to the mitral valve, the left-atrial appendage, the tricuspid valve, the right atrial appendage. Please note that the narrow mouth marks the junction between the vestibule and the left atrial appendage. And please note here that the attachment of the pectinate muscle is different in the right atrium when compared with the left atrium. Most of the pectinate muscle in the left atrium are within the appendage. On the left, you can see the septum. We need to identify what is the through atrial septum when we approach transeptally the left atrium. We need to distinguish that the through atrial septum is the fossa ovalis, and superiorly and inferiorly, this is not the septum, as can be seen in this slide. Note the left atrial side of the atrial septum. This is the venous component, this is the vestibule, this is the left atrial appendage orifice, the left superior and the left inferior pulmonary vein. On the right, you can see the left-sided aspect of the interatrial septum that is adjacent to the right superior and to the right inferior pulmonary vein. Here you see the smooth vestibule of entrance to the mitral valve that not always, as you will see, is not smooth. And here you see the area that correspond to the venous component. Different between the right and the left atrium is the area of the venous component. The interatrial pulmonary venous component in the left side, and the intercable venous component in the right side. Here you see the septum. We need to recognize the landmark to transeptal approach and to take into account that the superiorly and inferiorly is a fold of the superior aspect of the left and the right atrium, and inferiorly correspond to the inferior pyramidal space. This is the right side of the fossa ovalis. And please note here, this is the right atrium, this is the left atrium, this is the different attachment of the tricuspid and the mitral valve, resulting in the atrioventricular septum that can be seen here. This is the atrioventricular septum, and this is the through atrial septum, just the fossa ovalis. Superiorly and inferiorly, if we perform transeptally this approach, we go out of the heart, and afterward we go inside the heart, therefore pericardial effusions. And superiorly is the same, as can be seen here. Therefore, to approach transeptally this left atrium, you can see using angiography the anatomic relationship. This is the endocardial aspect of the left atrium. This is the aorta. And here you can see the orifice of the coronary sinus. This is the His bundle recording site that corresponds to the non-coronary sinus of the aorta. And this is the inferior pyramidal space. Transeptally, this approach, we go out of the heart. Therefore, anatomic relation, first, recognize what is the through atrial septum. Second, anatomic relation with the aorta. Here, this is anterior, and this is posterior. This is the left atrium. This is the right ventricle. And note the anatomic relation with the aorta. In this section from Damián Sánchez Quintana, you can see histologically the anatomic relation of this is the left atrium, this is the right atrium, this is the aorta, this is anterior, and this is posterior. This is the left atrial appendage. Please note that the approach anteriorly we go through the transverse sinus. And this is the risk of induced pericardial effusion in this area. The anatomic relation with the aorta should be taken into account when we are approaching the left atrial appendage. Also, please note here, this is the left atrial appendage, this is the right superior, the right inferior. Note that the left-sided aspect of the interatrial septum is adjacent to the right superior and the right inferior pulmonary vein. And now this is the orifice of the of the left atrial appendage. Landmark for transeptal approach. In this video, I don't know if the video is working. Can work the video, please? In this video, you can see the gross morphological feature of the left atrium. And it is important to note that the superior pulmonary vein are anteriorly orientated, the inferior pulmonary vein are posteriorly orientated, and the left atrial appendage is the more anterior structures in the left atrium. The left atrial appendage lies into the so-called AV groove, as can be seen here. Note from superior to inferior, this is anterior, this is posterior, and note the left atrium, left inferior, left superior pulmonary vein, and the left atrial appendage. This is the left atrial appendage. Here you can see an enlarged image, you can see the left atrial appendage that lies in the atrioventricular groove. Therefore, the epicardial aspect of the left atrium should be analyzed when we recognize that it's very close to the AV junctions, because this is going to give the extracardial relation with the circumflex artery, as we will see. Here you see the left atrial appendage. This is the AV groove. This is the aorta, the left superior, the left inferior pulmonary vein front, using the left superior lateral view. And this is the left lateral view. Please note the variable aspect of the left atrial appendage in this slide. Note the marked variability in the shape of the left atrial appendage. Here you can see fine specimen from Damián Sánchez Quintana, and please note different aspects. Several anatomical studies previously analyzed the anatomy using postmortem heart specimen, analyzed the left atrial appendage and described as a long tubular structure with different lobes. Here you see that in this postmortem study, using 2200 specimen, the volume can be seen here. The diameter of the orifice with this range between 5 to 27, the length of these tubular structures with a range between 16 to 51, a marked variable morphology of the left atrial appendage. In this quantitative study also they analyzed the orifice of the left atrial appendage, and they described that the orifice increased with age, and also showed that in some patients with atrial fibrillation, the orifice can be larger. Here you see the lobes in the left atrial appendage, 1, 2, 3. Most of the left atrial appendage have 2 lobes, 54%, and 3 lobes in 23% of the heart. Imagine study analyzed also the morphology of the left atrial appendage, describing the position of the tip of the left atrial appendage. Here you see that the tip is superiorly and anteriorly. In type B is anterior and inferiorly orientated, and here you see that the tip is posteriorly orientated. We can distinguish the morphology, the epicardial morphology of the left atrial appendage, taking into account the position of the tip. In this recent study, they showed that in those people with this finger-like anatomy or morphology of the left atrial appendage with the tip anteriorly and inferiorly orientated, increase the risk of embolic event. As you know, it has been recently described by the Biase, the CT scan morphology, MRI morphology of left atrial appendage, they show that this type of morphology of the left atrial appendage that can be found in 48% of the patients, the risk of induced of a stroke is, we have less risk of a stroke that can be seen. I think that Professor Zamorano will speak of this recent study. Therefore, we need to recognize the anatomy of the left atrial appendage. But probably when we perform transeptally and we go endocardially, what we need is to recognize the endocardial left atrial ridge for left atrial occlusions. And here you can see the anatomy of the endocardial anatomy of the left atrial of the left atrium as seen by CT scan. This is left superior, left inferior pulmonary vein, the mouth of the left atrial appendage, and the vestibule of the left atrial appendage. What are, in my opinion, in our opinion, the anatomic determinants that we should take into account when we are approaching this area of the left lateral wall of the left atrium? We need to recognize, first, what are the anatomic relation of the orifice of the left atrial appendage in relation with the pulmonary veins? Sometimes it's superiorly, sometimes it's more inferior, and sometimes it's at the level of the left pulmonary vein. Second, we need to recognize the presence of this lateral crest, the posterolateral crest of the left atrium. And we need to recognize the length and the thickness of this lateral crest. Please note the difference in these two specimens, left superior, left inferior, the lateral crest. Different thickness in this heart when we compare with this in this heart. Here is thinner. Also, the distance of this lateral crest to the mitral valve, the area of the vestibule of the mitral valve. Please note, a smooth vestibule of the mitral valve, and here you can see extra-appendicular pectinate muscle. It's like a vestibule of entrance to the left atrial appendage. And this extra-appendicular pectinate muscle that appear in more than 25% of the specimen is very important, because sometimes here we have, it's like a crest, it's like the thickness is very important. And also the extracardiac relation. Please note the anatomic relation with this circumflex artery. Here you can see, we are going to try to see the endocardial aspect of the left atrium, just to show that the so-called left lateral crest is not a crest. The lateral crest is a fold of the lateral wall of the left atrium, here you can see, extending from the superior to the inferior aspect of the left atrium, here you can see that it's a fold, and from anterior to posterior. Therefore, the crest is a fold of the left lateral wall of the left atrium. Here you can see the crest. One important anatomic determinant when we are in this area, the left superior, the orifice of the left atrial appendage, the left atrial appendage, the mitral valve, the left superior, the left atrial appendage. Please note the left circumflex artery here. This is the mitral valve. Therefore, the lateral crest, anatomic determinant. Here you can see the ostium of the left atrial appendage. The ostium is oval or nearly oval in shape. And here you can see the ostium, the variability of the ostium of the left atrial appendage. And the variability of the entrance to the ostium of the left fated appendage. The variability of this area here, you can see that several techniques can help us to identify the ostium, but sometimes even with the heart in our hands, it's not easy to identify the ostium because it's like a vestibule of entrance to this orifice. Here, you can see this ostium and this vestibule for entrance to the ostium of the left atrial appendage. That it is necessary to characterize this ostium when we try to occlude the left atrial appendage. Just as simple that if we want to choose the size of the occluder. Quantitative examination by our group described the diameter that can be seen here with the range between 10 to 24 millimeters, the larger diameter of the ostium of the left atrial appendage, the orifice, the shorter diameter with the range between 5.2 to 20 millimeters, the distance of the left atrial appendage to the left superior pulmonary vein with this range that can be seen in the table, and the length of the vestibule. These are quantitative measurements that we need to identify when we are planning an approach in this area. Here you see the width of the ridge. Please note that the width of the ridge changed from superior to inferior, from inferior, and even the thickness of the muscle in this area. Following with this lateral aspect, please note the presence of this extra-appendicular pectinate muscle. This is the lateral ridge. Here you can see the orifice of the left atrial appendage and the presence of this pectinate muscle. Look here. This is muscle, absent of muscle. Therefore, this is important because mark that the thickness is not uniform in myocardial tissue in this area. There are not a non-uniform myocardial content in the vestibule, in the entrance of the left atrial appendage. Here, please note the presence of this extra-appendicular pectinate muscle. This is the left atrial appendage, the left superior, the left inferior, the mitral valve, and please note by transillumination the absence of muscle. We need to recognize this measurement, the thickness of this area, and the length of this area. What is, from a myocardial point of view, what is this area of the left atrial appendage orifice? Please note the Bachmann bundle here connecting the superior vena cava with the left pulmonary vein and the left atrial appendage. Bachmann bundle anteriorly. This is the mitral valve. Here, lateral view, you can see the leftward extension of the Bachmann bundle. Therefore, what is epicardially the left atrial appendage? The left atrial appendage is surrounded by the leftward extension of the Bachmann bundle. The Bachmann bundle that connects the left with the right-sided and with the synod node area. And here, endocardially, here, the left atrium has been everted. Please note the left pulmonary vein, and this is the left atrial appendage. Note the lateral ridge. This area corresponds to the so-called septoatrial bundle. Therefore, there is like two layers composing the muscle of the mouth of the left atrial appendage. Epicardially, the Bachmann bundle, and endocardially, the septoatrial bundle. We know, electrophysiology, we know the relevance of this non-uniform myocardial thickness of the left atrium as can be seen here, because the risk of induced tamponade of perforation. But also, please note, in this area, this is the left atrial appendage. And note, this is the medial and this is lateral. This is medial and this is lateral. Please note by transillumination, non-uniform myocardial thickness. The lateral wall of the left atrial appendage at the level of the mouth, look, is thinner. This is 10 millimeters. We should take into account this anatomic aspect when we are approaching the left-atrial appendage occlusion. Please note here the vestibule to the mitral valve, and please note the area leading the ostium of the left-atrial appendage. This area has been described by Dr. Lopez Minger and Sanchez Quintana as the limbus of the left-atrial appendage. And they have tried to identify the variability of this limbus and its implication for occlusion of the left-atrial appendage. Here you can see the left superior, the left inferior. This is the left-atrial appendage, and this is the limbus is like a vestibule to enter to the left-atrial appendage. This is the limbus between the left lateral ridge and the vestibule of the mitral valve. And they have described three groups of three types. Please note here, this is the left-atrial appendage, the left-atrial appendage, the left-atrial appendage. This is the limbus. This is the limbus, and this is the limbus. Please note different thickness of the left lateral ridge, and superiorly the left-atrial appendage, thicker ridge of the left-atrial appendage, superiorly the left-atrial appendage, but thicker ridge, and thinner ridge, and inferiorly position of the left-atrial appendage. 3 slides and I finish. Just to finish the anatomic relation of the left-atrial appendage, we have identified epicardially the gross morphological feature of the left-atrial appendage, the variability, the implication in the risk of a stroke. We have identified the endocardial aspect of the left-atrial appendage, taking into account the thickness and the length of the left lateral ridge, the position of the orifice of the left-atrial appendage, and the presence of these limbus to entrance the left-atrial appendage orifice. But look here, the close anatomic relation of the left-atrial appendage with the circumflex artery. This is the aorta, and this is because the left-atrial appendage lies over the left atrial groove. Here you see the left sinus, the left-atrial appendage, and note the distance between the circumflex to the left-atrial appendage, with a range between 0.5 to 3.8 millimeters. This is 10 millimeters. This is circumflex artery. Also, please here, take your attention in this slide here. This is the left-atrial appendage, the left atrium, and in 40% of our hearts, we have the sinus-nodal artery arising from the circumflex. And here, anteriorly, you can see the anatomic relation of this sinus-nodal artery with the left atrial appendage. Not only the circumflex, but also the sinus-nodal artery. We can induce sinus-nodal lesion in this area. This is the ascending artery. Here you can see the circumflex and the left atrial appendage. And finally, note the anatomic relation of the left phrenic nerve with the left atrial appendage. The left phrenic nerve, epicardially located. This is the fibrous pericardium. This is the left lateral view. This is the left atrial appendage. And here you can see the left phrenic nerve. Please note in this slide the distance. This is fibrous pericardium, circumflex. Note the relation of this circumflex with the mouth of the left atrial appendage, the left phrenic nerve at this level. This is the myocardial tissue. And on the right, you can see in this transverse section, you can see the fibrous pericardium, the epicardium, the endocardial aspect, and the close anatomic proximity to the left phrenic nerve. In the table, you can see the distance. In some heart, with the range between 1.5 to 6.8. Therefore, this slide shows how relevant is the variable morphology of the left atrium, and how relevant is the close proximity to important structure that we should take into account when we are preparing our procedure. Thank you for your attention.